So this is the lecture number 4, and that's going to be about the P wave, its morphologies and pathologies related to the P wave and the PR interval. Okay, so the P wave is actually what the P wave is. It represents the depolarization of right and the left atria, and it's best seen in the lead 2 and in contrast in the lead V1 as well. So there is a rule of 2.5 small square for the P wave. Again, this is for you to remember that it's a to max it is 2.5 small square wide and a 2.5 small square tall. Okay, maximum, that's what I'm saying. The P wave morphology, it actually varies in any lead. That depends on the location of the area that is acting as a pacemaker. Okay, so if we talk about the P wave over here, say for example it's a P wave. So actually the SA node, it starts its depolarization theoretically from the RA. Okay, so if we divide the P wave into two portions, okay, so this one is represents the depolarization of right atrium, and this one represents the depolarization of the left atrium. Okay, what we're gonna study here is that what could be there in the P wave. Okay, um, as we said that it's a 2.5 small square wide and up to maximum and 2.5 small square tall. So it could be either more wide. This could be one thing. The other thing could be that the P wave is too tall. Okay. The other thing could be that the P wave is actually inverted. Okay, that's the third thing. The fourth thing could be there is no P wave. Or the fifth thing could be in an ECG strip, there are the P waves of various morphologies. Okay, like other one is like this. So these three are of the different morphologies. So we're going to discuss these 5 things. Okay, here. So let's start from uh, the wide P wave. Okay, the wide P wave, or what we call that P mitral. Okay, as we said earlier that the first portion, former portion of the P wave, okay, I'm going to draw over here, that is formed by the RA, okay, depolarization, and the later portion that is formed by the left atrial depolarization. So in the P mitral or the wide P wave or the notched P wave, what happens that there is a, this is actually in the left atrial enlargement. Left atrial enlargement. So what happens that the left atria is enlarged, so the duration taken to depolarize the left atrium is comparatively greater than the right atrium. So the right atrium, that this part of the right, okay, atrial depolarize, that's going to be the same, but as the time taken to depolarize the left atrium is comparatively larger, so the former portion is going to be like this. Okay, so that's an M-shaped or the wide or the P mitral. Okay, and this is exactly like this. Okay, so that's a wider P wave that's in the left atrial enlargement. Okay, the second thing we can discuss over here is, let me change the pointer. This is in the left atrial enlargement, that is a P mitral. You can remember it like this, that your mitral valve is on the left side. Okay, and the left side, if there's a left atrial enlargement, that's going to be because of the mitral stenosis there can be. Okay, so there would be the left atrial enlargement leading to the P mitral. The other could be that the P pulmonale, okay, or that is also called peaked P wave, okay, and that is in the right atrial enlargement. Okay, that is, you have a peaked P wave. I'm going to show these two things, okay, the P pulmonale and the mitral in the real ECG strips in a few minutes. So that's a peaked P wave as compared to this normal P wave. That's a peaked P wave. So it's taller than, okay, 2.5 small square. So vertically we knew that the small square was 1 mm. So it's like it's greater than 2.5 mm. Okay, it will be greater than 2.5 mm, and the idea is the same actually. No, here the R is enlarged. Okay, so the duration taken to depolarize the R is comparatively greater than the LA. LA is the left atrium, so that results in peaked P wave like this. Okay, P mitral. Here you can see a perfectly normal P wave over here. Oh, sorry, over here. It's a normal P wave. Let's see on the P pulmonale and the P mitral now. As compared to that, you can see over here, okay, in the lead 2, okay, that this P wave, this is a peaked P wave that is seen in P pulmonale, okay, that is seen in the right atrial enlargement, okay, because of the any reason. If there's a right atrial enlargement, that's gonna give up peaked P wave, okay, or the P pulmonale. Here you can see a wide P wave, okay, or a notched P wave. That is the P mitral that is in the left atrial enlargement. So let's look at some of the causes of the P pulmonale that leads to right atrial enlargement. There could be bronchial asthma, emphysema, pulmonary embolism, TOF, AST, and pulmonary valve stenosis. And the P mitral, as I already said, that is endomitral stenosis, could be in the mitral regurgitation and the aortic stenosis. Now the next thing is an inverted P wave, which you can see. Okay, so that is upside down, as you can see. The P wave is inverted. So inverted, normally what happens that, okay, from the SA node, the impulse originate and it goes down to the atria, okay? So it gives a normal shaped P wave, okay? When the initial impulse originate at or below the AV node, okay? So it will go in a retrograde manner, okay? That's how it's gonna go. If the initial impulse, it's not from the SA node, but it's originating, say for example, over here. So how it's going to depolarize the atria? It's going to go up. This means that it's going in a retrograde manner. So the what the P wave will be like, this exactly what is shown over here. And this inverted P wave, this actually the impulse that is spreading in a retrograde manner, that causes the inverted P wave. And this inverted P wave, it's a sign of ectopic atrial rhythm, okay? So it's actually from here, so that's depolarizing in a reverse fashion, giving a reverse P wave. So up to now we have discussed the P mitral, P pulmonale, and the inverted P wave. Now the fourth thing is that if we have different morphological P waves in the same ECG, so if you can look at the arrows, the morphology of this P wave is different from this one, and this is different from this, and then we have like more than three different P waves in the same ECG, okay, and the heart rate is that is greater than 100 per minute. So that is a multifocal atrial tachycardia that is commonly seen in the patients who are having a COPD, okay. And the lastly, it could happen that there is no P wave at all, okay, no P wave. So that's common. You all know that in the AFib, okay, there is no P wave because the atrias are fibrillating. Okay, so how there could be a P wave? There's no P wave. So these are the 5 things that are related to P wave. Next, we're going to discuss about the PR interval. So this PR interval, you can see over here, normally it is 3 to 5 small square, okay. What does this means? If we talk in another sense, that is every small square is 0.04, okay. So this means that it is 0 point somewhere between 0.12 to 0.2 seconds, okay. So if it's less than 3 small square, means 0.12 seconds, so that's going to be the short PR interval. And if it's longer than 0.2, that's going to be the prolonged PR, okay. So what are the different causes of the short PR interval? If you have retrograde junctional P wave, what we have already discussed earlier, if you have inverted P wave and it's arising from the junction, so that's gonna give you the short PR interval. The other thing is the Wolf Parkinson White syndrome. You know that there's a short PR interval. The third thing is there's LGL syndrome. Okay, that gives you a short PR interval, and the prolonged PR interval. You all know that in the AV blocks, there's a prolonged PR interval. So the PR interval, the normal value is 3 to 5 small square, that is 0.12 to 0.2 seconds. It could and it should be seen in the rhythm strip. Okay, so it could be prolonged, the conditions I told you. Like AV blocks, we're gonna discuss the AV blocks in a separate video, and short could be in the retrograde P wave, it's a junctional P wave, and WPW, that's we're gonna discuss in a separate video, and LGL syndrome. Thank you.